Free Clinics: A Solution to Bridge the Healthcare Accessibility Gap by Batty. Reggie's story. I'm still here because I went to the clinic, says Reggie, who's an uninsured, hardworking adult who is currently in remission from stage 3 prostate cancer. Reggie had previously lost his job and therefore also his health insurance due to being in a coma for 5 days, which meant he could not work. Reggie had worked 7 days a week for long, hard hours for the past 20 years of his life, and now to be out of the job without insurance coverage he needed, he could no longer afford his regular medications and necessary treatments post-coma. He found out about the free clinic, and, as he claims, it saved his life. He went for routine visits to receive various treatments for different issues, receive medication, and also attend physical therapy. At the clinic, the doctors realized that still there was something wrong, so they sent Reggie to a specialist where he was diagnosed with stage 3 prostate cancer. They not only covered the fee of the specialist, but they gave him extra assistance to go and receive treatments at Duke for 2 months and then continued to support him once he returned home and finished his treatments, entering into remediation. What I learned is this clinic is so important for people like me, he explains when talking about his experience at the free clinic. I thought people would treat me real bad, but they treated me with respect and dignity. They saved my life. Introduction. There are many people, like Reggie, who do not have health insurance and who cannot afford the high cost of receiving medical assistance. In the United States alone, 36.8 million people were living in poverty as of 2023, according to the official poverty measure of the U.S. Census Bureau. We know that the poor often suffer more health complications and die at younger ages than their counterparts in other socioeconomic classes. These health complications include having an increased risk for mental illnesses like depression and anxiety, as well as various chronic diseases. Studies have shown that children living in poverty are 3 times more likely to develop mental illnesses in the future than their higher income counterparts. Additionally, this poor mental health contributes in part to the stickiness of poverty and its generational cycle. Furthermore, it is important to understand that of the people experiencing poverty, the largest age group is children. It is widely studied that childhood poverty is detrimental to not only mental health, as mentioned previously, but it also causes developmental issues, toxic stress, chronic illnesses, and nutritional deficiencies. Also, we know that in today's world, healthcare and health insurance, especially in the United States, is incredibly expensive and is out of reach for many poor and even some middle-class Americans. Like Reggie, 26 million Americans as of 2023 did not have health insurance, and this represents about 8% of the U.S. population. While government programs like Medicare, Medicaid, and the Children's Health Insurance Program aim to help more people become insured, there are still so many people who either don't qualify and cannot afford insurance, or even still a large population of people that do qualify for these programs, but there's not enough funding for everyone to be covered. However, is the lack of insurance the only problem here? If you were to ask someone like Paul Farmer, Harvard MD PhD, and medical anthropologist, the answer would be no, and that the problem goes beyond insurance. Farmer would claim that this problem is truly about accessibility and that healthcare should be a human right and not have all of these barriers to entry. Additionally, if you ask someone like Jack Shonkoff, founding director of the Center of the Developing Child, the answer would still be no, as you would probably hear something about how development and health outcomes later in life can largely be attributed to the impact of the social determinants of health, specifically during development. Overall, we see that a lack of insurance is just scraping the surface of this problem, why people in poverty suffer and live with so many detrimental health problems. So, if insurance coverage is not enough to satisfy the health of all people, impoverished or not, what can we do about this? First, we need to understand the social determinants of health and how they play a large role in health disparities between the rich and the poor. The term social determinants of health is kind of vague and leaves a lot unanswered. According to the Centers for Disease Control and Prevention, social determinants of health are defined as the non-medical factors affecting health like socioeconomic status and geographical location. For example, people who live in poverty often live in areas where there may be bad air quality or excessive pollution, which in turn would then impact their health negatively. Another example is that of the argument made by Janet Curry regarding maternal health and its incredible importance in the development of children and their later outcomes and achievement in life. Mothers experiencing poverty oftentimes do not get the care they need, and they also have more external stressors like the need to work a more physically demanding job, or even just the stress of trying to make ends meet that is not experienced to as much degree as mothers who are in higher socioeconomic classes. In sum, the social determinants of health and the works of people like Curry, Shonkoff, and Farmer are very important to understand when looking at links between poverty and human health. Now, to answer the earlier questions about the approaches to increasing access to healthcare if not through insurance, I would like to pose a new question about the expansion of free and charitable clinics as a safety net for individuals in need. Free clinics. Free clinics, as their name suggests, are nonprofit facilities that provide care to patients in need that are usually funded primarily by private donors. The first free clinic was founded in the 1960s with the goal of providing quality health care for people with economic disadvantages. These clinics were created before government programs like Medicare and Medicaid, so their patient population was composed of individuals who could not afford other forms of health care or health insurance. Since then, there have been many changes with the addition of government-funded programs as well as the implementation of the Affordable Care Act in 2010, which is a healthcare reform law that expanded health insurance accessibility. This act provided the premium tax credit to families 100 to 400% below the federal poverty line, thereby lowering the cost of health insurance and their cost of receiving medical care in general. It also increased the Medicaid coverage to all adults 138% below the federal poverty line, with the overall goal of investigating new and innovative methods for lowering costs of healthcare, like funding federally qualified health centers that will be discussed later. However, it is important to note that not all states chose to expand their Medicaid policies with the Affordable Care Act, so there is still quite a wide gap between those who are federally eligible to receive Medicaid and those who are actually eligible and chosen to get the coverage by the state. Following this act, free clinics adopted additional roles of helping people navigate through this new process of both acquiring insurance as well as providing and increasing access to both routine and emergency care. In addition, due to this gap from the differences across states, in some places there is now a larger uninsured population in need of free clinics, especially in recent years following the pandemic. Today, there have been over 1,400 free clinics and pharmacies open across the country to serve the uninsured as well as the underinsured communities. However, free clinics are usually overlooked and not brought into the conversation of bridging the gap in the healthcare accessibility of the United States. Historically, free clinics are seen as inefficient and a random scattering of resources in the eyes of policymakers, as they are only a short-term solution to the much bigger issue working towards universal healthcare. However, this does not mean that they're not important. Yes, we need to try to fix the social structures behind all of this that causes these disparities, as we want to fix the problems for the people of the future. But we should still care about the people who are currently suffering. This is why involving free clinics in the conversation is essential to expanding the healthcare safety net. During the pandemic, people started to see that free clinics were actually very important in the system of providing care to low-income individuals. As it is argued by Mark Hall, a leading scholar of health care law, public policy, and bioethics, by focusing on the neediest portions of the population and people who don't seek care elsewhere for various reasons, free clinics can reach difficult to contact people and those who face perceived or real barriers to obtaining care from other safety net providers. The other safety net providers Hall is referring to here are the federally qualified health centers and public health departments. FQHCs are government-funded safety net clinics that take both uninsured as well as a few Medicaid patients. The main difference between these safety net providers is that FQHCs and public health departments are largely funded by federal and state government and therefore have a lot more barriers to receive care, as Hall argues, than a privately funded free clinic that does not have to collect as much invasive information, which is not as intimidating as some of these government-funded providers. This is often the reason why free clinics are a much larger part of the safety net system, in Hall's opinion, than one might think, as they can support a wider range of people in various states of need. However, it's important to consider the other differences between these two types of clinics. Free and charitable clinics rely mostly on volunteers, while the FQHCs utilize federal employees to do the work. This is important to take into account because it means that free clinics may need more assistance, not only in regard to funding, which is covered by the private sector, but also needs large numbers of volunteers to actually run. This could be a barrier to the expansion of free clinics in a way that maintains their private sector funding as well as potentially some government aid without the clinic necessarily becoming an FQHC. At the end of the day, both free clinics and FQHCs are incredibly helpful and should be given more attention in this conversation about filling gaps in healthcare access. Conclusions. So, why is this important in our discussion of poverty and inequality? The mission of the Shepherd Program is to understand and address the complex causes and consequences of poverty and inequality in ways that respect the dignity of every person. If we want to respect the dignity of every person, we need to respect their well-being as well as their autonomy. Free clinics protect both people's well-beings as well as their autonomy by providing access to quality health care for people suffering in poverty while also giving them choices regarding their own health. Martha Nussbaum and Amartya Sen teach us from their works about the importance of protecting one's capabilities through the capabilities approach of defining poverty. Free clinics open doors for people by increasing their capabilities of living a normal length life as well as protecting their bodily health so that this life is not just a good length, but it's also of good quality. To be treated with dignity is essential. You cannot and should not have to live day to day where you're not respected and you're made feel little or made feel less than due to your circumstances that are sometimes out of your control, especially in poverty. As a political philosopher, John Rawls would say, we should try to alleviate those who are the most burdened, who suffer greatly. These free and charitable clinics are so important because now people living in poverty who are suffering the most burden not only have access to health care, but they can afford in emergency situations, but they can also take initiative and get routine checkups to prevent potential detrimental health issues in the future by catching problems early on, thereby improving not only their physical, but also their mental health in general. Moreover, free clinics also alleviate financial strain on people, which itself can lead to improved mental health by lessening the health issues associated with the body's biological mechanisms of handling stress, including hypertension, depression, and anxiety, and even more. In a study done by Anuet Rees and their team, it was observed that 37.1% of those surveyed said that they would not have gotten care if it were not for the free clinic. Likewise, 94.7% of all people said their health had improved significantly since joining the clinic, which speaks to the quality of care and effectiveness of the system. In addition to improving one's health and well-being, even when asked if paying a facilities fee for care at the clinic is appropriate, 81.6% of those surveyed agreed, or strongly agreed, that it is appropriate because it makes them feel more respect and dignity. In conclusion, to use a philosophical question as a frame for my argument, imagine a scenario where you and a friend are going fishing in a nearby river. You see kids floating down the river towards a steep waterfall, so you help them out of the river. But more kids keep coming. You discover a hole in the fence by the elementary school and see that more and more kids keep falling through. You can either go up and help patch the hole in the fence to prevent more kids from falling in, or you could stay and save the kids already in the water. What do you do? Well, to equate this to the driving questions we have about free clinics, let's look at the scenario through that lens. Millions of Americans are without health insurance and suffering without receiving appropriate medical care or are going into extreme medical debt because of it. Our current healthcare system is a hole in which millions of Americans slip and fall through the river. People like Paul Farmer want to patch this hole with our big plans of changing these unfair and frankly unjust social structures. However, we cannot forget about the people drowning in the stream, heading towards the waterfall, about to fall off. Patching the hole will take time that these people just don't have as they're actively suffering. We need someone to stay behind and pull the kids out of the river. We need a safety net to catch the Americans slipping through the cracks. That safety net in this scenario is largely composed of free and charitable clinics who give aid to the poor by improving their well-being, as well as giving them choices to get routine checkups, to see a therapist, to get prescription medicine, to have regular screenings for various detrimental diseases, receive dental care, feel supported, and so much more. In sum, free clinics are vital to bridge the healthcare gap in accessibility, and therefore they're an important topic to explore if we truly care about protecting the health and the general well-being of all people. Thank you.